Good morning. Thanks for joining us. As I get started, I just want to let you know, please feel free to get up and get more coffee, more fruit, whatever, during this presentation. So it's going to be kind of nice because we usually have a lot of clanking dishes, so this is going to be a lot easier. So, but anyway, do feel free just to get up and get some more coffee and stuff. Okay. So I welcome you. My name is Dot Weir. I'm one of the, I'm going to moderate our session this morning. I'm a nurse and I'm a clinician at Saratoga Hospital Center for Wound Healing and Hyperbaric Medicine in Saratoga Springs, New York. And I'm very proud to and happy to be here to moderate with some good friends and esteemed colleagues that are joining me up here. Martha Kelso, who is also an RN, and she's the founder and CEO of Wound Care Plus, a group that goes into mostly long-term care facilities, and she'll tell you more about her practice when she tells you about her research. Also, we have Dr. Alton Johnson, who's an MD, who's a plastic and aesthetic surgeon with a subspecialty in wound healing in Washington, D.C. We're also joined by Dr. Alton Johnson, who is the Chief Assistant Professor and Attending Physician at the University of Michigan School of Medicine. He's a podiatrist in the Division of Metabolism, Endocrinology, and Diabetes. That all fits together really nicely to me. Dr. Charles Anderson is joining us. He's the Chief of Vascular Surgery, Vascular, Endovascular, and Limb Preservation at Madigan Army Medical Center in Tacoma, Washington. And so we will get started. I'm going to set the stage a little bit with just some information about how we have used the MolecuLight technology in our clinic. So we all treat wounds, and we've been treating them a long time. And I was talking to some people earlier, because one of my biggest, I think, passions and soapboxes when it comes to especially educating the caregivers and nurses is about wound cleansing and wound hygiene. I'm part of that whole platform, so this really speaks to me loudly. So we all treat wounds all the time, and we think we know what's going on. So it's like, what really is there to change? So when we were introduced to the concept of using fluorescent imaging in our practice, we realized, and we know this, that early removal of bacterial loads, getting rid of that surface bacteria, can really reduce, and Martha's got good data to show this, really reduce our rates of infections, and it just helps our wounds heal faster. It's complex. That's a fragile environment. And so we talk about it in our wound hygiene platform as it being like a war zone. And we want to do is move it into being more like a rose garden. So it's peaceful and it's going to be conducive to growth. So we know if we have the right tools and the right concepts, but also the right mindset of how we're going to approach that, we're going to have better outcomes. So I'm also part of the International Wound Infection Institute, and this diagram was adapted from our guidelines, which you can download the brand new guidelines at International. If you just go to International Wound Infection Institute, then you can download the new guidelines. And it's a continuum that we see in a lot of different presentations and talking about biofilm. And we know that most wounds have some level of biofilm. How much is there is impossible to tell most of the time because you can't see it. But I want to point out a couple of things about this, though. I hope you can see the screen. We know that all wounds are contaminated. If the bacteria is replicating, we would consider it to be colonized. But, then we just do good wound care. But there is a tipping point when those bacteria build up to a more critical mass where it's going to start impacting healing. But the most important for me on this slide that I want to point out is over on the right-hand side. It's how we sort of visualize biofilm. There's a really great paper by a guy who's on our International Wound Infection Institute, and he wrote a paper called The Mental Model of Biofilm, and he pointed out to us that because we see a lot of diagrams like this where the biofilm is sort of sticking up like mushrooms, we have this idea that they're easy to get rid of. But they do penetrate down into the tissues, and I know that you know this. But that's Tom Barnsfield, and I'd be happy to share that article with anybody that wants it. But when you hear that phrase, the mental model of biofilm, it really makes us think about how we are describing how we're getting rid of this sort of yellow stuff on the top and assuming that we're getting rid of the bacteria. So if I say to any group, which one of these wounds do you think has a high bacterial load or a biofilm, I would suspect that most people would point out like this one and up here, but we don't really know. And so that's where fluorescent imaging has changed our view, if you will, and our ability to see that. So I'm very happy that, you're looking at the tools that are in our toolbox. We use an antimicrobial cleanser 100% of the time, one that's safe and non-toxic. We are very blessed. This shows, doesn't exactly show the one we have, but we also have an ultrasound, which has changed our ability to clean. But then we also have gauze, and I'm going to, for the nurses and those that do the wound cleansing in the room, I'm going to show you some pretty alarming things with gauze. But anyway, we also have the MolecuLight. We had the IX at first, and then we went to the newer model, the DX, and it really has been practice changing, and I'll share that with you. So what are they? Well, what it is, it's a point-of-care imaging device that uses a safe violet light to help detect the presence of bacteria. And we can do this, and then it helps to sort of guide us in where we're cleaning and where we're debriding. But what's nice about it is it doesn't require any contrast agents, and there's certainly no patient contact. In fact, I will tell you that our patients think it's pretty cool because we have to turn off the lights to do it. We're real lucky, I guess. We're in an old Sears building, and so they needed to use those stores for something, right? So our hospital, at least, has a tremendous amount of space in our mall, and so we don't have any outside windows. So we turn our lights off a lot with the patients in the room. But they do find it's pretty cool because we share the images with them, and I'll show you that. So what you have is the device, this is just showing it used. It emits a purple light, and you'll see that in a minute. And so it fluoresces. The bacteria send back colors, if you will, that's filtered. And what they have found through their clinical work is that if we see these colors, and I'll describe the colors in a moment, that what we're looking at is greater than 10 to the fourth, or greater than 10,000 colony-forming units of bacteria. It's not diagnosing infection. It's telling us where the bacteria is sitting. So it does help tremendously, and these folks would agree with this, that it helps to guide our care. So it filters out other lights that are colors that are being emitted to avoid any kind of confusion. And we do this, of course, in combination with our clinical assessment, looking for signs and symptoms of infection. So the colors that we see, most people will describe them as red or blush or scarlet. And when we see that color in the wounds and a lot on the peri-wound skin, then we're usually looking at just most forms of bacteria, most species of bacteria. I'm going to come back to yellow. When we see a cyan, a bright sort of hot white color, that is very specific to Pseudomonas. And so that, again, helps to target our cleaning. Anything that's very keratinized, scales, skin, is going to have a cyan or a green color. So some very recent information that has come to light, if you will, is that when you have a lot of keratin, like a callus, for example, the keratins are going to be the green color. So, you learned in our primary colors, and you mix this, you get this. So the whole point is you can't really treat what you can't see. So I'm going to show you, this is this first image of this wound. But before I do, I want to point out a couple things. So you have these scales, hyperkeratotic scales in the area that, have been exposed to the wound, have been exposed to the wound exudate. Some pretty benign looking stuff here. The skin doesn't look great, but it certainly doesn't look infected. And so when we image that, what you see are these areas of red coloration, and again, that's telling us that there's bacteria. It doesn't tell us which kind, but it does tell us that there's bacteria that's at least 10 to the fourth. Our platform with wound hygiene is that we not only clean the wound, but we clean the peri-wound skin, and that has absolutely been driven home as we've imaged so many wounds now at this time. So here's an example case, and this is a video that will play. This is actually Monique, their scientist, and I in one of the rooms with one of my patients, and I'll just let you watch it. So what we're doing is we get a real image, but you can see the color, and we're just focusing in, and then it's showing me where the focus of my cleansing would be best. So the green that you see around it is mostly just the keratin, but the red is actually what I'm going to go after, so I'm pointing that out. It's always nice when we can use it in somebody. I'm going to show you a couple other videos that's going to almost make you seasick, because when I'm trying to clean and hold it at the same time, it's different than when somebody else is cleaning it, so or holding it. So if I can, I get our MA or somebody to come in the room, but most of the time I'm by myself, but Monique was helping me here. You can start to see, you see the red or the pink on the gauze. This has really taught me that we need to change our gauze out frequently, and it gets worse. I'll show you more. So anyway, that's in one sitting before and after cleaning, so I feel much better, putting that second dressing on, especially this was a lady with lymphedema and venous insufficiency, sort of phlebo lymphedema, that we were wrapping and putting a wrap on for a week. So I feel better about doing that when I know that I've gotten a good, clean wound bed. So this one, again, I'm sorry, I'm holding it, so it's sort of rocky-rolly, but look at the gauze for my nurses that are doing the cleansing. Look at the gauze. It doesn't mean we're not going to use gauze. It'd be nice if we could all use microfibers or monofilaments, but a lot of us use gauze. We just need to change that gauze out frequently, because it really is, it's on my gloves, it's on my gauze, so. And that's the before and after. Here's another one. This is using the ultrasound. And again, you see the before and after. But this is really my favorite kind of example to give. This patient, the other important thing to know about the colors, can you see that sort of horseshoe-shaped dark stuff is collagen. When you see healthy granulation tissue looks dark under here. So that's all good wound, and I failed to put the regular image in. But what I'm getting ready to do is going to cover that again and leave it for a full week. So the wound bed itself is fine, but there's all that peri-wound bacteria, so we want to not trap that for a week. Under a dressing. So, oops, I forgot to start that. So again, sorry for the rock and rolling, but again, you can see it on the gauze, and you can see that I can target where I'm cleansing. Toenails look very white, just so you know. They're hard keratin, so they fluoresce very white. So again, I'm going to sound like a broken record, but I would point you to what's all over my gloves and all over my. But this one is my favorite. So this is a gentleman. We were actually taking care of a venous leg ulcer, and he was complaining about a corn that he had. And what it was the corn was macerated. It wasn't infected. But so we imaged him first, and oops, I'm putting the point. So this is look at your toe spaces. Chuck has done a tremendous amount of work looking at cleaning toe spaces, because there's some bad stuff that hides in there. And so the next, oh, darn, hold on. Let's see. Oh, my video's not playing. Could you click the middle picture? Because that's the important thing. So how many of you do toe flossing? Oh, it's so satisfying, but it's really sad. It is, and it's really satisfying when you can see what's coming out. So look at my gauze. Now we use Vosh, a hypochlorous acid for our only wound cleanser, and so I do have hypochlorous acid on that gauze. But that's toe flossing at its best, but look at the final picture. Where we also have macerated skin, we see a lot of absorption or bacteria that stays in there, and so we need to work on that. But again, I was at least able to get the toe space clean. So it's been incorporated really seamlessly. People say, well, doesn't it take more time? Well, there's a learning curve, but it's moving around in our clinic constantly from room to room to room. It can be wiped down with cavity wipes, so you don't have to worry about contamination. But it really helps our assessment. It does have the ability to measure the wounds, which does have a very nice measurement feature that with the newer version is very, very accurate. So it helps us during our procedures, and then to check that especially our cleaning and our debridement procedures have been effective. So it's been incorporated into a lot of other practices. It's optimized some care, and Martha's going to be talking about that. So what our challenges here and what we're going to focus on today is looking at some of the disparity that's out there in healthcare. We want to look at how can we use this to optimize our care in long-term care and vulnerable populations like that. Looking at the diagnostic equality when we're looking at dark-skinned individuals, and then help us to have new ways to diagnose and treat patients. So now it's my pleasure to turn it over to Martha, and Martha has led a lot of adoption of the MolecuLight imaging in the skilled nursing facilities that her very big company goes to in the Kansas area, I think. She'll tell you more. But this is, again, an area of vulnerable patients, and so long-term care is not an area that gets a lot of attention in terms of newer technology and newer modalities. So Martha is going to share with you not only how they've used it, but some of the important data that she's found. So I thank you, and I'll be back.
Good morning. I'm Martha Kelso. I'm the CEO and founder for Wound Care Plus. We're the largest mobile healthcare group in the Midwest, and I think we're third, fourth largest in the nation, something like that. We're currently active to treat in 20 states, and we touch about 22 sites of care. So although we primarily adopted MolecuLight in the long-term care setting, we do use it across the continuum. So assisted living, homes, residential cares, group homes, LTACs, inpatient acute, Indian Health Services, so on and so forth. And Dot, do I hit that fun button right there? Okay, I didn't want to break the machine and have to call an adult. That'd be terrible. So, I grew up in the long-term care sector. I actually started as a nurse aide when I was 15 years old and fell in love with nursing home patients. There's nothing better than dancing with a demented patient in the hallway, trying to get him to go to dinner. And I miss those years. So it's near and dear to my heart, even though I've worked inpatient acute and even in the operating room as a first surgical assistant for an orthopedic surgeon. So when you found wound care, that's what I want to give back to, the healthcare sector that I fell in love with when I was so young. But I feel like the long-term care skilled nursing population are the most underserved. And oftentimes when you hear me present to payers, you'll hear me tell them this is the nation's retired poor. With wound care, Dr. Bryce Schuster has this great quote where he says, "Wounds are a barometer of health." And there's nothing more true than the elderly 97-year-old walking dead. If you ever see one of my expert witness testimonies, you'll hear me say, these are people that should have died 20 years ago. But through the miracles of modern medicine, they're living longer and longer, sicker and sicker, with the most polypharmacy and the most ICD-10 codes known to man. But they rarely give us the magic wand to come in and heal these wounds. They don't give us arsenals in our toolkit. So when I realized what was happening with this device a few years ago, we decided we wanted to be some of the early adopters because we understood the benefit of the technology for the sickest of the sick, okay? We know that the impacts of aging on wound healing are detrimental. These are the guys that don't have the cascade effect, so they rarely mount fever responses, even when they're septic. Less than 50% of the elderly run a fever when they're septic. So we get stuck relying on clinical signs and symptoms of infection to determine wound infection, and yet they're not accurate. I call that 1980s wound care. And in a medical legal world, it means we're going to get sued more and more because we're not diagnosing those infections. And yet, there's nothing there to help us. But yet, enter bacterial fluorescence, right? And so we also know that pressure ulcer infections are more frequent in nursing home patients. We know that 1/3 of all deaths in the seniors are from infections. And we also know that many elderly present with non-specific clinical signs and symptoms. John, how you doing today? Well, is it because he didn't sleep good, or is it because he has a UTI, or is it because he's septic from his wound? You know, I'm okay. What does that mean? And then we have to put on detective hats, and usually by the time we trace it down, they're in the ER is hotlining us, and, you know, enter the lawsuit. Super fun. So we realized that we wanted to not only adopt MolecuLight, but then actually figure out, is it making a difference in our senior population? So we determined that we were going to do a research study. We wanted to know, does MolecuLight help with heal rates? Right? Is it making a difference with heal rates, not just determining presence of infection? Is it helping with our antibiotic usage? Are we using it more? Are we using it less? What about cellular tissue products? We don't want to put CTPs on infected wounds, right? If you're putting CTPs on infected wounds, you're feeding the infection. You're feeding whatever's in that wound. And then also PCR microbiology. Those tests run payers sometimes up to $400 a pop. So are we doing it just because we're scared of getting sued, or are we doing it because it's medically necessary? And then the rate of complications from a wound infection. And what about real-world evidence? I do clinical research often, and there's a lot of inclusion-exclusion criteria. Well, is that really the population that I'm treating? Not always. And a lot of clinical research is done at outpatient wound centers or inpatient acute centers, not the sickest of the sick, not the aged and infirmed and retired and, you know, lack of payer source. So what does real-world evidence show? We also wanted to look at pressure injuries, but also mixed etiologies. I believe 60% of the time wounds have mixed etiology. And so, and 93% of what we treated was full thickness wounds. So we're not talking about baby wounds. We're not talking about wounds that just occurred. We're talking about some of these wounds had been there 6-7 years, okay? So let's see what the research showed. What we did was we decided with the real world evidence, once we started pulling, we wanted to get a good sample size of, we didn't even have the device in our hands. So we knew when we purchased the device, which means everybody that was admitted from January 2019 to March of 2020 is a really great sample size because we didn't even have access to the device. Ha, easy to do, right? So we had 52 patients with 89 wounds. We performed debridements and used clinical signs and symptoms. But then we purchased the device. So now we know we have a nice sample size, and we grabbed patients that were admitted to our company between February 2021 to March 2022. That was 61 patients with 104 wounds, and we performed fluorescence imaging. They did have to have Medicare as a primary insurance to be eligible for this study. Well, guess what? In long-term care, that's 80% of my clientele. Okay, good deal. I held my breath. Really, really nervous to do a research study on technology that has not been adopted nationwide in the long-term care sector. And I believed the technology was working, but until the results came out, we didn't know. And the results were beyond what I could have ever imagined. So we found that when we did MolecuLight, those wounds were 5.3 times more likely to heal within 12 weeks, not 16 weeks like the national standard, 12 weeks. On top of that, we also found that the percent of wounds that healed at 12 weeks were significantly statistically significant. The average duration of healing was also statistically significant. And then you can see our treatment weeks on that arm. The wounds with MolecuLight, the heal rates without MolecuLight never did catch up. So we had 80% more wounds that had healed at the 12-week mark. 80%. Guess what? We just moved past 1980s wound care. On top of that, we had a 12-week wound healing rate that doubled by incorporating this image. Now keep in mind, we're not adding more CTPs, we're not adding more debridements. The only change in this population was being able to see bacteria at 10 to the 4th power with the naked eye. Okay, so our standard of care, percent of patients that were prescribed systemic antibiotics was 48.1%, and we had 17.3% of patients with severe wound complications. Once we added MolecuLight to our standard care, we dropped systemic antibiotic prescriptions by 25%. Now I'm preventing C. diff, confusion, falls with fractures from confusion because we're not having to prescribe systemic antibiotics in our elderly population. Additionally, we dropped severe wound complications by 53%. Severe wound complications defined as amputations, sepsis, hospitalizations, or gangrene. So, the most aged, the most vulnerable, the most critically ill, we demonstrated some pretty outstanding outcomes when implementing this technology. The other thing is, because it is non-invasive, my demented population are not afraid of it. So they're not hitting me, kicking me, punching me, or trying to squirm away from me when I'm trying to use this device. That's important. I don't want people afraid of me when I come in to treat them. And I'm saying me, but my clinicians or providers. We also know that we have the multiple severe, lengthy comorbid issues and the most polypharmacy. On top of it, it's in line with our antimicrobial and antibiotic stewardship and surveillance efforts. So Medicare's not afraid, the surveyors are not afraid, family members are happy, and it helps with our quality assurance performance improvement, both at the nursing home level, but also at the Wound Care Plus level. And I'm going to turn it over to Dr. Johnny Johnson. Thank you so much.
Thank you, Martha. And I think, she takes care of a population that are vulnerable, elderly, and frail, so this is so critical. But we're going to now change and look at another area that I think we would all agree, but maybe don't think about as an area of healthcare disparity, and that's how things affect people of color. We think about it when we think of pressure injuries, don't we? It's hard to assess and see subtle changes in skin color. Well, the similar challenges will be presented when we're looking for subtle and early signs, clinical signs of infection. So we're going to have a multidisciplinary group now talking about this and looking at assessing the state of these wounds with leading up with Dr. Johnson and then Dr. Anderson, and then Dr. Alton Johnson will also talk about his role in education and looking at this, again, disparity. Dr. Johnson.
All right, good morning, guys. How are we doing?
Great.
First of all, thank you, Dot. Thank you, Martha, the rest of the team. Glad you guys are here this morning. We have an excellent topic that we're going to discuss. We've looked at some bacterial burden issues and how we can remove a lot of the issues with the bacteria. We've focused on MolecuLight. Now we're going to switch and look at closing gaps in racial disparities in our diagnosis of chronic wounds. So let's look at some of the major issues that I think we're all familiar with in healthcare in general. Obviously, there are factors that contribute to racial disparities, and we can see these different aspects here on the slide. We can focus on implicit racial bias, ethnic bias, et cetera, healthcare coverage, which focuses on access to care. So a lot of these specific points focus on why there's a discrepancy in different groups obtaining health care and becoming more healthy and focusing on preventative measures. So chronic health conditions are an issue. Healthcare research can be underfunded. Mental health can also be an issue. But probably one of the most efficient or the most aspect that we need to focus on is social determinants of health. Specifically what environment you're in, specifically where you live, and specifically your access to care. So skin tone diversity is lacking in wound care, and I think we can broaden that topic to healthcare in general. I remember when I was going through my training, rarely did I see images, periodicals, research aspects, et cetera, that focused on skin of color. So what we wanted to do was look at how we can utilize MolecuLight from a standpoint of decreasing some of that racial bias and looking at some of those issues. So a couple points. Only 5% of images in the general medical lecture focus on skin tones of color. And we can definitely understand that pressure ulcers are likely to form more in patients of color. They're typically going to be more severe, and specifically in nursing home residents, as Martha was saying, where you're going to see a higher incidence and they progress to infection quicker. As well as a survey that around 64% of providers were not aware of how to treat these specific wounds. So obviously, based on these concepts, there is a huge gap in knowledge, and there's also a gap in evidence. So what can we do moving forward to make sure that we decrease those issues? So as we all know from a clinical standpoint, infection presents differently based on your skin tone. So what we're looking at as far as observing the wound or quote unquote eyeballing the wound, sometimes being able to observe signs and symptoms of infection can be difficult in skin of color. So obviously the bacterial load, the more bacteria we have at the wound site, the more progressive the wound can become and the worse the wound can progress to. So essentially, you have high bacterial loads, and these high bacterial loads obviously increase the rate of infection, specifically some of our comorbidities as well. We have diagnostic indicators of infection that we can see that lead to those issues, specifically erythema. We can look at induration, et cetera. So what are our objectives? So we focus on two main objectives. Number one, determine how reporting the clinical signs and symptoms of infection differs by skin tone, specifically emphasizing erythema, and explore the fluorescent imaging, MolecuLight, to bring a more equitable solution to patients with high skin of color. So how did we focus on that? We looked at a great acronym. You know, in medicine, we all love acronyms. FLAG, correct? So the acronym stands for Fluorescent Imaging Assessment Guidance, and we focused on about 350 clinical and chronic wounds in about 14 different outpatient centers, looking at the very common types of wounds that we focus on a daily basis: DFUs, VLUs, our pressure ulcers, et cetera. And we analyzed the information looking at three specific concepts. Number one was patient skin tone. Number two was clinical signs and symptoms of infection. And number three was the total bacterial load and looking at the progression of MolecuLight working on those loads. So the Fitzpatrick scale is key, right? I remember back when I was going through clinical studies, you're trying to figure out what the Fitzpatrick scale means. Really, the summary is how your skin responds to sun, how it responds to some of the issues with increased sun, obviously, and decreased sun. I know in our aesthetic office, when we are doing our laser treatment, we're always doing a skin spot test first with the laser to make sure we don't increase risk of burns, hyperpigmentation, et cetera. So in our study, we focused on our low, medium, and high aspects of the Fitzpatrick scale. And we can kind of take a look at the different types of the Fitzpatrick scale. But essentially, number one is that you burn very easily and you don't tan too well. And number six is that it's difficult to tan and burn. So some of our results. Number one thing we saw was that erythema was detected often less in our higher skin tone patients. So if that is key, looking at our clinical signs and symptoms, how do we reverse some of those issues? So clinicians flag up to 5.6% or 5.6 fewer wounds with erythema in patients with highly pigmented wounds. Now, one of the most important aspects that we focus on is that the more bacterial load, the quicker, from a progressive standpoint, the wound can worsen. So infection was detected less often in higher skin patients, and some of the disparities in our wound infection assessments were not focused specifically on the erythema, it was focusing on that bacterial load. So from a sensitivity standpoint, how do we change some of the issues from a clinical standpoint? All right, so from a fluorescent standpoint, imaging increased with detecting some of that sensitivity. Most importantly, the fluorescent imaging allowed clinicians to identify more at-risk or clinically infected wounds. Specifically, what the slide is saying is that from a clinical standpoint, if you're observing the wound, you may not be able to recognize some of the clinical signs some of the clinical signs of infection with erythema and induration, but using your MolecuLight, you can see some of the changes and more adequately affect and take care of that wound. So the benefit was most pronounced in patients with higher skin pigmentations. So we're looking at the fluorescence imaging here. So I use MolecuLight in my long-term care setting. I think it's awesome because it allows us to see some of that bacterial load that we may not be able to see from a clinical signs and symptoms. So if we look at our low, medium, and high, we can focus on some of the changes. So if we're focusing on the upper left, that low skin pigmented patients, these are your Fitzpatrick 1s and 2s, you can definitely see your changes with your bacterial loads. And if we move to the lower area of the slide, you can see some of that cyan, as we discussed earlier, which is progressive of Pseudomonas. And then from the middle side, we can look at some of the medium aspects of skin pigmentation and some of the high aspects of your skin pigmentation. So at this point, I think Dr. Anderson, who has a breadth of knowledge working with skin of color, is going to come and chat with us a little bit about results and some of our clinical examples.
Good morning. So you can't treat what you can't see. So what you're hearing is that using clinical signs and symptoms alone, you have a low likelihood of being able to pick up 10 to the 4th bacteria by what you see. But we know when you get to that level of 10 to the 4th bacteria, that has a detrimental effect on that wound's healing and it also sets the stage for a more aggressive infection. What you've heard is it's even harder as you get dark-skinned individuals to assess whether or not there's 10 to the fourth bacteria in the dark-skinned individual. They do not present with the same degree of erythema or clinical signs or symptoms. What you're hearing is that we have a device now that regardless of the skin tone, you're able to pick up 10 to the fourth bacteria. It doesn't matter whether it's light skin or dark skin, you can still pick up the 10 to the fourth bacteria. So just a couple of studies just to make a point. So these are dark-skinned individuals. When you look at the image, what you see is, looking at the image, you would have a very low threshold to thinking that that patient was colonized. So both sides. But yet, when you look at the adjacent picture, oops, sorry. When you look at the adjacent picture here, you can see the fluorescence indicating bacteria. Again, clinical signs and symptoms, you really have a low threshold of thinking there's bacteria. But when you scan, you can see the bacteria. In addition, and Dot pointed this out very well, in addition to that, you're able to now make sure that once you identify that bacteria, that after you cleanse, after you debride, then you have a scorecard. You can rescan that wound to make sure that you have removed that bacteria. So what that allows is a very proactive approach to preventing infection. We had a cohort of patients that had pressure injuries, as you see in both of these patients. By identifying the bacteria early and aggressively treating the bacteria, none of those patients went on to require hospitalization. So we were able to treat the bacteria and prevent that infection from going on. The wounds either stabilized or healed, so a proactive approach. So again, you see here the image, you see the bacteria, you see after it's cleansed, you see the other image, which again shows that the bacteria is gone. This is to me, was an exceedingly important case. So I'm a vascular surgeon by trade, and if you end up with a vascular surgery graft infection, that can be limb-threatening, it can be life-threatening. This is a patient that had critical limb ischemia, had a bypass, and what you see here is, this is the incision for the bypass. When you scan, you see a little bacteria here. This is a counter incision. Right underneath that counter incision is a bypass graft. Now, when you scan that and you look at the image, there's no fluorescence around that. So you would say, gee, a little fluorescence on the wound. We're not in any trouble. What we've started doing, and we had a poster that we presented yesterday, is in addition to scanning the wound, we scan dressings and we scan wicks. So this is a dressing that shows fluorescence. This is the dressing that was right here. This is a wick that was in that wound that has bacteria. We call this now our C-swab test. This is a cotton swab, excuse me, and if you put that in the wound, then you're able to ascertain whether or not there's bacteria in the wound. So bottom line, based on the C-swab, based on the dressing, based on the wick, there was bacteria in this wound. By being very aggressive, we put this patient on antibiotics, we did antibacterial type of dressings. That patient went on to heal without any evidence of a graft infection. A very proactive approach to preventing a graft infection. So again, this is another patient. This is a patient that has very severe Charcot foot, a rocker bottom deformity. We had this individual all healed, and then he decided on a holiday weekend that he was going to go out in the yard and barbecue and kind of forgot his offloading shoe or dressing and came back in with an acute wound. When you scan the wound, it's not that impressive, but again, when you look at the dressings, when you look at the drainage from that wound, clearly has bacteria. So this is not only now a recurrent ulcer, but it's a recurrent ulcer that has greater than 10 to the fourth bacteria. So you're setting the stage now with a very acute wound that could potentially get infected and lead to a very bad outcome. So getting aggressive in debriding, cleaning that, this is 1 week later. You can see the dressing no longer has the bacteria, and that patient went on to heal. So some take-home points. You've heard a lot this morning. So looking at the clinical signs and symptoms alone, you cannot discern whether there's 10 to the fourth bacteria. That's been shown in a large study called the FLAG trial, that it's inaccurate, and in a high percentage of cases, you miss the point that there's bacteria. By using this modality, you're able to pick up the bacteria, whether it's light skin or dark skin, and then you can then go on to a proactive approach in treating that. What we've added more recently is that we're scanning a lot of things besides the wound. So we're scanning dressings, we're scanning wicks, we're scanning shoes, we're scanning insoles. As Dot showed, we're scanning between toes, we're scanning pants. And what we find many times is that those patients that are coming back with recurrent infections have another source of bacteria that, if unrecognized, will continue to feed that recurrent infection. So how can we, I think that gets turned over to you.
So I think this really does sort of close out what you guys have been talking about, and then we're going to get some insights from Dr. Alton Johnson. But we want to look at how we can reduce this disparity. So education is key, and so Dr. Alton Johnson, I'd like you to speak. We wanted you here with us to speak to your experience, because you have a lot of experience serving treating underserved populations. And your thoughts on how medical education, or just education in general, could make a difference in those patients.
Yeah. So thank you, Dot. So just an introduction to me. So I am a podiatrist at the University of Michigan. So I'm part of the hospital system at the university. Before obtaining this faculty role, I was at the University of Pennsylvania in Penn Medicine in Philadelphia, where the majority of our patients were all underserved, or high need patients, because of the location in West Philadelphia for access for that city. So I spent 2 years doing that, and then I ended up taking this role here at University of Michigan, which now is similar because we're getting the Detroit overflow, but we also have rural health. So this is all going into how it ties into why they brought me on the panel and why I decided to help with this research project that they are conducting, or they conducted, or we conducted. But with that being said, it is very challenging treating these patient populations that are underserved, no matter what skin tone you're going with. So even going back to what Dr. Anderson's saying, regardless of the Fitzpatrick scale that this patient or phenotype they display, you can use this device as an empowerment tool to educate the patient on what's going on with their wound. So now they're actively involved, which Martha basically alluded to as well, and Dr. Johnson. So you've actively involved the patient into the care, and now they have almost a pick in the fight with it. Even though they know it's their wound, now they can see what you're seeing, and now you kind of educating those patients. And then it also helps from a standpoint of educating future or upcoming providers. So at my institution, I train medical students, podiatric medical students, fellows, family medicine residents, internal medicine residents, and of course, podiatry residents that are all trying to understand how do you treat a wound, because we all learned it different ways. We all know there's not a set way of learning it, but now you have a standard, so you can use the device, fluorescent imaging, to actually help decrease, disparities, and also enhance those individuals' knowledge. So from that standpoint, that's why I really kind of got onto it and was excited about it. And then also from an institutional standpoint, to get these type of devices in, it's not you can have the best research out there, but they still want to see how is this device going to make a difference in the patient's care at the end of the day. And now we're bringing that DEI side on. I'm one of the DEI scholars at my institution, and I'm also one of the medical education innovators. Very few podiatrists decide to take those type of roles, so you have to come up with ways to be creative to explain to these institutions why these investments are worthwhile investing, to basically equalize the playing field for your patients. And that's really the best angle to go with it, because I know it is, the device itself isn't, it's not cheap, but none of our grafts are. Nothing in wound care is really cheap or inexpensive. So it is, that's the best way I would say of going about it if you are in an institution. So yes, Martha kind of works for herself, Dr. Johnson works for himself, so they can kind of pull off those type of feats. But for me, I got to come more creative standpoint. So I got to say, well, now I'm using this to empower our patients. Now they can see that, I can't miss an infection. That's easy when I can, fluoresce these imaging. I can show them fluorescent imaging, and I can actually bring them as an active member in their care. I can bring in their, their caregivers actively into their care. And then I can also use it from an aspect of medical education. So now we enhance this basically, whoever comes to rotate throughout the wound care center with me on how to approach these wounds, especially in diabetic foot ulcerations. They always hide infections. It's really hard, no matter what skin type. I mean, I could name 5 of them just from last week that I had to send to the hospital of all skin types. So it's just more so to have that in confidence for being a diagnostic provider for your patients, and really just an enhancement tool. That's what I would say. I don't know if there's any follow-up questions from the audience or from Dot.
Thank you. So for my panel, do you have any other parting thoughts before we open it up? Any other comments? Chuck, I have something for you. So, did you hear him say he's fluorescing shoes? Because how many just really nasty shoes do we have come walking into our clinics? What do you do with that information? We also, the underserved aren't just of color and living in bad places. Right now, economically, people are having challenges, And so if you are finding nastiness in somebody's shoes, what do you do about it?
I think whether it's skin in between the toes,
Is the green light on?
No.
Live.
I'm not sure how to make it live.
I don't know if it'll reach.
Just come up here. Come on up with me.
There you go.
So the question is, what do you do with that information? This is an ideal opportunity. Part of I work trying to prevent amputations in diabetic patients and to heal wounds and return patients to full function. Part of that, patients have to be part of that team. And when you can show a patient, gee, you have bacteria on your pants, when they say, gee, I laundry my pants every day. Well, they don't. Or when you say, gee, how often do you change your socks? Every day, but then you scan the socks, you turn them inside out, and there's a lot of material there, and some of that material has bacteria. This is an opportunity to educate patients, but you can also change things. You can change inserts, you can change shoes, and certainly you can change the way the patients wash their feet, which I think is exceedingly important. Toe flossing, once they see that, and we use the MolecuLight as a strong educator of patients. We show them the image, and once they see the red between their toes and you say, you know, that could well lead to a bad diabetic foot infection. You need to wash between your toes. You need not to put lotion between your toes. And the next time you come in, we're going to check your toes. Patient education.
Awesome.
Yes, sir.
Suggesting that you can use this imaging modality to validate. Thank you. Can you use this imaging modality to validate a swab before you send it to the lab? Like you do the swab, you're ready to put it in a tube, but
Yeah.
what if it doesn't have bacteria on it, and you're just wasting your time waiting for 3 to 4 days? Maybe redo the swab, or is this a potential validation of the swab? Because I saw you showed that images with the swab with the bacteria, so that was interesting.
I think the beauty of having it, and we're all feeling very blessed to have it, is that you can target or guide your cleansing and your debridement. And then you can target or guide where you're going to take that swab from. So yeah, make it a more meaningful swab.
And I might hop in also. We target like Dot said, our debridements, but the more shocking thing is if you've sharp debrided and it's still fluorescing, you know exactly where to culture. Where it was and this is outside the study, but it was shocking to me to see how many times we were culturing the wrong part of the wound and getting a negative culture back when the wound actually if you're dealing with a wound this size, it doesn't mean the whole wound is infected. It might just be at the 6 o'clock of the wound, and we were randomly selecting a spot, and so guesswork gone.
So,
Oh, before you put that, you've got to pick something up. Well, on his sterile applicators, he's showing that. That's kind of brilliant, Luke. I think you need to do a study. But yeah, that makes perfect sense. I hadn't thought of it in that way, though. Yeah.
so we just finished a study. We looked at 421 consecutive patients where we scanned not only the wound, we scanned dressings, wicks, anything that was associated with the wound. In 80% of those patients, the scan changed our treatment. Now, many times, there's a feeling that every time you see a positive scan, that patient needs to be on antibiotics. That's absolutely not true. This actually helps in antibiotic stewardship because you can see the bacteria, you can cleanse it, you're not waiting for 2 days to see if there's a positive culture or not. So it allows you to be very proactive. But the C-swab, we're finding very, very useful. So again, in that 421 patients, half of those patients that now 80% change, 40% of those had something positive other than their wounds. And that oftentimes, one patient recently, we removed a dressing, and on the side of the dressing, away from the wound, was clearly a red spot, a fluorescent spot. We cleaned the wound, debrided the wound, went over to look at that area where the fluorescence was on the dressing, and we were able to unroof a significant abscess. So.
And just to piggyback, I think understanding where in the wound bacteria has an increased amount is huge. And just to piggyback off what Martha is saying, after debridement, you want to make sure that the wound is clear, but also specifically for cellular tissue product grafting. So we use it prior to our grafting to make sure we have a clean wound bed to make sure that wound can heal progressively.
Excuse me. I have a question. Of course, I use MolecuLight. Been using it for over a year now. I think one thing that is not mentioned here is the false negatives. There are bacteria that are not picked up by MolecuLight. So the gentleman's question of doing a swab, and if the swab is negative, don't send it for culture, I didn't want him to go down the wrong path. Correct me if I'm wrong.
I think the statistics are that MolecuLight's, and Dr. Rooney's going to correct me if I'm wrong, it picks up 93% of bacteria. It's 93% active. So, when I worked tele in patient acute, you do treat the patient, not necessarily the monitor. The monitor is definitely your guide, but it's not your end-all to end-all. So if your clinical gut is telling you it's truly infected and MolecuLight's not fluorescing for you, culture anyway.
I think the literature quotes that streptococcus and enterococcus are not picked up
Correct.
by MolecuLight.
Yep, that's
And,
correct.
and that's a significant load in my practice. Two other questions. How do you keep the older model steady to take a picture?
Didn't I make you seasick with my pictures?
No, you were using the newer model. The older model is
The-
elongated. It's very difficult with one hand to hold it and take a picture. I don't
The
know.
newer one's not any easier, I'll tell you that.
Really?
I mean, it's a little heavier, but most of those videos were with the IX, not the DX.
Okay.
Yeah, so, it's nice if I can have our MA or another nurse come in, but that's not always difficult, able to be done in a clinic, as you know. And so, if it's moving a little bit and you're making a video, it is, but, and some things you need to use two hands, so then you may have to get another person in the room. But I usually just do it myself. I'm usually in with our provider, and so I'll be holding it, so that makes it easy for them. When I'm doing my cleaning, I'm alone, so it's a little hard.
One last question, and this is probably for the industry guys. Do y'all make a sterile covering for this to use in surgery? Good, great, thank you.
And we do, and I think that's important. Remember, we're washing and cleaning and touching this thing, but you can use cavi wipes to clean it in between patients. I think Martha wanted to make one comment, and then we'll go to the next question.
Well, just to follow up on, I mean, it's a team approach. I mean, wound care in general should be you need a team. But specifically for us in long-term care, we're not only doing the lower extremity, we're also doing pressure ulcers. So you're looking at the sacrum, the coccyx, buttocks, et cetera, and you need someone in there to help you. But once you get the form down, it's easy.
Just to comment on your first question, which I think is very, very important. No device is a substitute for a good clinical assessment. So to say you're just going to treat on the basis of a MolecuLight and ignore your clinical finding, you're going to miss some important infection. One very important, this does not evaluate cellulitis. If you do not have an open wound and you're looking at the skin, this does not tell you if you have cellulitis. So that's an error that sometimes is made. It does not pick up streptococcus. Again, it can be a very virulent infection. So you have to use your clinical assessment. But what it does pick up is a lot of bacteria, a large number of bacteria that you cannot see. Now you can proactively address.
And I will say, until you get used to using the device, you have to rely on the MolecuLight team. So when we first went out in the field and really started using it, we went through the training. There's a whole training on how to interpret, so on and so forth. And then you think, I got this. Man, I know my colors, and nope, I'm not going to need to call anybody. Within the first week, I said, I don't know what this is. There is something fluorescing under the skin. It's not the wound. We've already debrided the wound. The wound looks great. This is 2 centimeters to the lateral medial side of the wound. And I had to pick up the phone and say, I need to send you guys an image. And so, Ashley Jacobs came back and said, I think you have a hidden abscess. And it was really close to the rectum. And so we injected, numbed it up, did an incision and drainage, and we drained 20 cc's of purulent material. And that person would have had a perirectal abscess, fistula, by the time we came back the following week. So we found at least 7 hidden abscesses that we would not have identified with the naked eye. And so on the flip side, it does find some very shocking things, but we rely on their team. I mean, even 2.5 years in, there's still times we're still calling them going, I don't know what I'm looking at, can you help me? So, yep.
There you go. Hey.
Hi. So in the beginning, you had said at your facility you love and you use this, but you don't use it as your tool to help measure wounds. So, and you said something about the newer model changing or upgrading. So can you comment on that?
Well, the DX is just an enhanced, with the IX, we had to use these little green dots, and then now we just can trace it on there with our finger and then enhance that tracing with a style app. The reason, did I say that right? Ashley? Yeah. So the reason we don't is we got several patients back at the same time. Our MolecuLight's going back and forth, so we don't take the time. We measure with our ruler still just because of the time. If I've got it and somebody else needs it and I'm doing the measurement and I got to take this measure. Anyway, it's really a function of, a lot of people do use it to measure, we just don't.
Do you use it to measure, Dr. Anderson?
Do y'all use it to measure?
Selectively, maybe. Again, we're running very busy clinics, room to room, and
We don't.
A lot of times do not take the time.
Can you speak to using it intraoperatively for like neck fash, making sure you have all the infected?
Neck fash,
intraoperatively,
intraoperatively.
Dr. Anderson has.
We have used it intraoperatively. It gets back to, we had a very, very interesting large case in the operating room. Patient had big flaps, and it was a condition called morale level A, where you get a hematoma that dissects under the skin and you have big, large flaps. We were able to demonstrate, again, taking some gauze, going under the flap, and then scanning the gauze to tell whether or not there was bacteria under that flap. So we have used it in the operating room.
Did you have anything else? His microphone's off still. I don't know if they.
Yes, we've used it in the operating room.
Yeah.
And if anyone didn't hear the answer, yes, there is a sterile sleeve that can be used in the operating room as well.
Okay, what was the,
I have some rookie questions. I've never used this technology. First of all, you say you can detect 10 to the 4th bacteria. That sounds like a numerator. Is that per square millimeter, per square micron?
per gram, like CFU per gram of tissue? Just
Per gram of tissue, okay.
yeah.
Got it. And the second is, any comment on what causes the spectrum of emission, fluorescent emissions? Is it protein structure? Is it, like you mentioned keratin and you mentioned collagen, which are very structural proteins.
Yeah, I'm going to direct your attention.
Is
to
there
the
a scientist in the room?
I don't know how to
I got you.
This is Monique Rennie, who is the scientist for MolecuLight.
So the red fluorescence is from something called porphyrins. Porphyrins are produced naturally as part of the bacterial heme metabolism pathway. So that's what you're seeing as red. The vast majority of bacterial pathogens are porphyrin producers, with the exception of Streptococcus and Enterococcus and Fingoldia. Those are the three that don't fluoresce red. Fingoldia. Fingoldia? And then what's producing the cyan color from Pseudomonas is a virulence factor that it produces called pyuverdin. That is different from pyocyanin, which is the greenish tinge that you're used to seeing on dressing. So this is a different virulence factor, and it's actually more common than the pyocyanin, which is why you'll detect Pseudomonas examples with the MolecuLight that don't have that classic, so-called classic signs and symptoms of Pseudomonas.
That's what we were going to say, but thank you.
That's not what I was going to say, because I didn't know. And it was, as you mentioned, Martha, there was a learning curve, because I started thinking everything that I was seeing that was bright green, with Pseudomonas, but it is that hot white that's sort of surrounded. But you do really get to see and appreciate scales and just dry hyperkeratotic skin that needs to go. I have scanned some scales, peeled them off. So I know you like to toe floss. Does anybody like to pick scales?
I do.
Okay, we all could have fun together. But you can peel them off and then fluoresce the back of them, the skin side of them. And what you've seen taken off scales, sometimes you see like macerated skin underneath it, but there's definitely bacteria in there. So it helps us to know, even if you don't have the MolecuLight, you can say, wow, I realize that there is bacteria there, so I think it helps us all strive to do better skin cleansing.
So I just had a question, I guess, with the long-term care patients. You did debridement and you did all those things, the good wound care before, and saw a vast difference. So how did it change the practice in terms of, was it just more debridement, deeper? Was it just better cleaning, or what was different?
There was times where we weren't debriding wounds because they didn't look like they needed debrided. They looked great, no redness, no erythema, no fluctuance, no unstable eschar. So it's normally you would, we better just keep doing what you're doing. Then you fluoresce and you go, oh, holy cow, that's not right. And so it actually, I know there's been other research studies on it, but I believe that it changed our clinical practice plan of care 80% of the time or more. 80%. And that's clinician reported. So it's not me going through my database, it's my clinicians saying, Well, I walked in thinking I was going to do this, and I walked out doing that instead. And there was also times we ended up culturing when we thought the wound was totally fine. And so obviously with a decrease in heal rates of 5 weeks, that's massive. And it's massive cost savings. But it's shocking. I don't know. I was always so frustrated because I've been doing mobile for 12 years. So our providers would go in, say on, say Tuesday, and the wound they've charted, it looks great. I can see the photos. And by Thursday, they're admitting them for sepsis. And this, not like once or twice, this is a repetitive issue. So man, are those long-term care nurses just shipping our patients to the hospital because they don't trust us? And then why is the hospital admitting them for sepsis? That wound looked great 2 days ago. There's no way. And then you get this and you go, now it all makes sense. Yeah, so.
Another finding that we have reported on is even with the MolecuLight and your selective debridement and your thorough cleansing, there's a subset of patients where you see a subdermal or a dermal extension of bacteria, and we've labeled that wound-related cellulitis. So it's early cellulitis, but again, you can't see it with the eye, but you can see it with the scanner. In our experience, looking at a cohort of patients, it was 6.2% of our patients had wound-related cellulitis. Those patients we put on a very short course of antibiotics, and that early cellulitis responds very promptly.
Your poster or paper on that is available at your website, at the MolecuLight website.
I had one more question, if that's okay. I know I love using hypochlorous acid to clean wounds. Do you see any difference? Because we know that it dives deeper down in the tissue. So do you see any difference, or can you tell with the MolecuLight, like just wiping? Because it seemed with just wiping, the fluorescence kind of went away, but then we know it helps if you can let it dwell a bit as well. So do you see any difference there?
That's been our standard for 12 years, letting the hypochlorous acid soak, and for the buildings that allowed us. But of course, fast forward 12 years later, and most of our buildings have adopted hypochlorous acid too. And that's a question we all get frequently, as does Dot and this panel. But like, are you just using saline? No, we're using hypochlorous acid, doing the right thing to begin with. And so it's actually why some of these statistics are so shocking with the long-term care research. So.
One of my patients, I fluoresced, you may have seen that there was a little bit of the red color left. When we have those kind of patients, we'll bring them in and we'll first do a 10-minute soak. And then we'll numb them up, we'll do the cleaning or the debridement, and then, so I think it enhances it a lot. Was there something else?
You want to talk about acetic acid?
Yes.
A question about culture, because so once you start doing the imaging, right, and then you see all the different colors there, so how do you culture now?
We don't culture any different. We're still going to drive we're going to still culture based on a clinical signs and symptoms. This just enhances our ability to recognize where it is, clean and debride better, and then hopefully not need or feel, have the wound progress on to a truly infected wound where we see the clinical signs and symptoms. We're still culturing based on clinical signs and symptoms. What Luke brought up and what they were talking about is that, do you use it to say, well, that's exactly where I want to take my swab, and if you've debrided down, I think that would be an ideal place. If you're going to culture with the intent to treat, we had a session on that yesterday, or sometime, then you're still going to use the same signs and symptoms. What I have a question of, and I'd be interested to know your feelings, we talk a lot about biofilm, and, we had Tom Barnschult's mental model where we think we see it and we don't. If we've done a good debridement and then we still see imaging, isn't it possible that we've unroofed the biofilm? We've released planktonic bacteria, so it's probably going to enhance our type of culture, the results of our culture. You can see the bacteria or visualize the coloration change when it's in a biofilm, but it doesn't diagnose the biofilm. But if we've done a good debridement, we might release the bacteria that's in the biofilm. Does that make sense, Monique?
Yeah, so
Okay.
so you can see through the biofilm
Yeah.
to see the bacteria, but it doesn't distinguish biofilm from a
Can't tell the
planktonic
difference.
bacteria.
And I also recommend, instead of just doing a swab, just actual tissue culture or bone culture. I mean, in our department, we basically stopped doing swabs because they can be dangerous. Martha and I was kind of discussing that on the side because you could be giving a patient a strong antibiotic that's not really, colonized there, but it's not infectious. So I recommend trying to get a tissue culture or a bone culture of that area instead of just swabbing.
My counter to that is just that most people do swabs, so we still have to have people do the best possible swabs. Did anybody come to Culture with Intent to Treat? I won, didn't I? Okay.
That's true.
Susie's not here to defend herself. Oh, hey.
Sorry if you spoke on this and I missed it, but is there any fungal detection with this device?
No, there's not. Yeah.
When we culture, when we do culture, our standard of care for Wound Care Plus, we always send for aerobic, anaerobic, and fungal. And some of it's medical legal. Dot does expert witness work too, but it's always like, if you do get sued, and they say, well, why didn't you culture for fungal? To me, it's like, well, saying, well, I only like looking at 2/3 of the pie versus the whole pie. So we always send for aerobic, anaerobic, and fungal. If you're taking a piece of their body, a tissue culture, and sending it out, you might as well test for all three, so, yeah.
Yes.
Same for us.
Hi, my name's Lynette Morrison. I work with Martha
Yes,
at Wound
hi,
Care
Dr.
Plus,
Morrison.
and I'm a collaborating physician, wound care specialist with Wound Care Plus, and I just wanted to speak to the MolecuLight ability for telemedicine.
Yeah.
Since I'm in Arkansas, I supervise nurse practitioners in all different states, and they're waiting for my guidance for what to do in terms of debridement. Does a patient need to go to hospital? What needs to be done? So I can look at their images, I can look at their cultures and their MolecuLight images and say, this is a pretty, severely infected wound. They need to go to the hospital. So it also helps guide those kinds of decisions.
Just from a practical standpoint, that's a great comment. Come to SAWC Spring in Washington, D.C. on the telemedicine talk. But utilizing MolecuLight from a telemedicine, it's perfect because you can download everything immediately after you finish seeing the patient, upload it, and all the clinical providers can take a look and know where to move forward as far as clinical management.
Back to your question about cultures, using the MolecuLight, it has decreased significantly in our institution the number of cultures that we obtain, and it also has significantly decreased the usage of antibiotics.
I had one other question about the hospitalization. I'm in acute care, and I'm kind of the front line of, I'm a physical therapist, but I certainly say, I think we need vascular involved, I think we need infectious disease involved, that sort of thing. Sometimes if the hospitalist misses things. Does this help, I guess, in advocating for the patient? Because I get that a lot of we just sent this patient out, everything looked great, and then they're sending them right back to us, and if the hospital is not utilizing the MolecuLight, do you get patients back that weren't treated fully, if that makes sense?
Yes, often. And the hospitals, because they don't have MolecuLight, don't always understand what it is. And so honestly, reaching out, making that phone call and sending them, I send them the flag study all the time. I send them Dr. Anderson, Dr. Orapollo, Dr. Johnson, Dr. Johnson. I send them the clinical research by email so they have a chance to review it. Because I know they're going to go to their infectious disease specialist and say, what the dealio? Is that what they say? Okay. They're going to say, what is this device? How is it being used? Is it a piece of quackery? We've never heard of it before. And so having those studies, which MolecuLight can give you in digital format or whatever to send on, and then if it does fluoresce, I'm telling you, if I really think they're septic and it's that bad, we turn around and send them right back within that same few hours of admission, because the hospital doesn't like that. But if they are really septic, I don't want them under my watch. I can't treat them in the long-term care space if they're septic. And so, yep.
And we would be happy to provide any publications. There's over 60 on MolecuLight now, including randomized control trial evidence, and you can find them all on our website, or you can reach out to any of us and we'll provide them.
And we do have an 800 patient study getting ready to come out in the not getting ready to come out. We're in the middle of getting it together and getting the data pulled, but we're not talking small patient studies. That Medicare study was 193 wounds, so not 14, yeah. Big data.
Did we answer all your questions? Well, thank you so much for joining us. I guess the next session will be starting soon.